Welcome to the session Hemodynamic Perspectives Beyond the Daily Horizon. In this lecture, I talk about the vasopressin effects, but not only about the effects on the arteries and the vasopressor, but also on the other effects on the circulation. And these are my disclosures, and these are the points I want to focus on in the next 15 minutes. So what is vasopressin? What are the clinical indications of vasopressin administration, and how is the clinical evidence? And what are the other effects on the arteries, the kidney, and the central nerve system? So at first, what is vasopressin? So vasopressin is a hormone. It's also called antidiuretic hormone or arginine vasopressin or agipressin. It's synthesized in the neurons of the hypothalamus. It has a very short half-life time with 16 to 24 minutes, and it works on the vasopressin 1 and 2 receptors. And vasopressin is a component of the renin-angiotensin-aldosterone system. To remember the physiology, if the patient has a decrease of renal perfusion in the juxtaglomerular apparatus, for example because of a drop of the blood pressure, renin is increasingly being produced. This indicates the transformation from angiotensinogen, which is produced in the liver, to angiotensin 1. Angiotensin 1 is split through the angiotensin converting enzyme to angiotensin 2. And this leads to an increase of sympathetic activity and to a tubular sodium chloride and potassium excretion and water retention. And this also boosts the aldosterone secretion, and it also increases the vasopressin secretion. So what is a clinical indication to administrate vasopressin to our patients? So the medical information indicates the use of vasopressin in the treatment of catecholamine refractory shock in adult septic patients. So some years ago, the VAS trial was published. And in this trial, they investigated vasopressin versus norepinephrine in patients with septic shock, with a minimum of norepinephrine dosage of 5 micrograms per minute. The primary outcome was death from any cause and was assessed 28 days after the start of the infusion. Secondary outcomes were, for example, the 90-day mortality and days alive and free of organ dysfunction during the first 28 days. Over 800 patients were randomized, and you see regarding the primary outcome, there was no significantly difference between the groups and all patients. You can see here in the Kaplan-Meier curve that the probability of survival seems to have a little trend to a better outcome in the vasopressin group, but without any significance. The authors also defined 2 subgroups of patients prospectively. Patients with more severe septic shock were defined as those who required at least 50 micrograms of norepinephrine per minute at the time of randomization, and the patient with less severe septic shock were defined as patients with 5 to 14 microgram of norepinephrine per minute as at the time of randomization. And the results showed trends in favor of the vasopressin group in the less septic shock group regarding the 28-day mortality and the 90-day mortality. Vasopressin was also investigated in cardiac surgery patients. So the VANCS trial investigated in over 330 patients after cardiac surgery with a vasoplegic shock the use of vasopressin as a first-line vasopressor in comparison with norepinephrine. And they could show in the vasopressin group a significantly higher event-free survival regarding the primary outcome. The primary outcome was a composite outcome of mortality and severe complications within the first 30 days. And here you can see the composite outcome, the combination between the 30-day mortality, the mechanical ventilation for more than 48 hours, standard wound infection, reoperation, stroke, and acute renal failure. And how you can see here, the vasopressin group had also less acute renal failure in comparison with the norepinephrine group. And the patients of the norepinephrine group had significantly more atrial fibrillation, and they stayed significantly longer at the ICU and also in the hospital. So what are the other effects on the artery, the kidney, and the central nerve system? I think we all know the vasoconstriction effects of vasopressin, which is V1 receptor mediated in the arteries. It comes to an increase of intracellular calcium concentration, and that leads to a vasoconstriction of the vessels. An experimental study on different arteries could show that vasopressin has no effect on the pulmonary vascular ton, in contrast to all other vasoconstrictors. Here you can see the vascular ton of the human radial arteries. All vasoconstrictors had an effect on the vascular ton. And here you can see the human pulmonary arteries, and you see all vasoconstrictors had an effect on the vascular ton besides the vasopressin. So this might be important for patients with a pre-existing pulmonary hypertension, where probably vasopressin should be preferred. We also know that vasopressin is also called antidiuretic hormone. So it has three main effects on the kidney function. And these effects are V2 receptor mediated. So the first is the increasing water permeability of the distal and the cortical collecting tubulus. And this leads to an increased water reabsorption back into the bloodstream and excretion of more concentrated urine, and therefore a higher blood pressure. It also increases the permeability of the inner medullary portion of the collecting duct to uvea. And the third one is an increase of sodium absorption across the ascending loop of Handler. And this also leads to a proper water reabsorption later in the distal tube. We also know that vasopressin is synthesized in the hypothalamus. So it also has some effects on the central nerve system. So vasopressin is released in a circadian rhythm. The vasopressin release is also associated with nausea. And there is some evidence that it may have some analgesic effects depending on the stress level and the sex of the patient. So some factors can influence the secretion of vasopressin besides the low blood pressure. Of course, angiotensin II stimulates the vasopressin secretion in keeping with its general pressure and provolemic effects on the body. The atrial natriuretic peptide inhibits the vasopressin secretion, in part by inhibiting the angiotensin II-induced stimulation of vasopressin secretion. Also, the cortisol inhibits the secretion of vasopressin, And some animal studies in an animal study, it seems that alcohol reduces the calcium-dependent increase of vasopressin by blocking the calcium channels in the neurohypophyseal nerve. So I want to conclude my physiology-based talk about vasopressin. So we know vasopressin is a natural hormone, and it is also a medication. It belongs to the renin-angiotensin-aldosterone system, and the effects are receptor-mediated effects. The V1-mediated effects are the vasoconstriction of the vessels. The V2-mediated effects are renal, with increasing the water permeability and increase the water reabsorption. We have an increase of sodium absorption and an increased permeability to urea. There are also some effects on the central nerve system. So vasopressin is associated with nausea and may have some analgesic effects. The clinical evidence shows that it is a really potent vasopressor and could be used in combination or also first line in patients with a vasoplegic shock, in cardiac surgery patients, or in patients with a septic shock. So I thank you for your attention, and if you have any questions, you can write me an email.